So in terms of our first panel, that is uniting people and policy and people, aligning state vision with local voices in behavioral health. We're pleased, and I will invite Kirsten Barlow to come on up and get us started here if I can. Kirsten, for those who don't know, is fantastic. She is our behavioral health guru up with the California Hospital Association. So Kirsten, thank you.
Good morning. I'm Kirsten Barlow. I work on the policy team at CHA, so based up in Sacramento. Work with many of you, particularly if you have folks who in your emergency department are really interfacing with behavioral health issues, or have a hospital that operates psychiatric inpatient care. And today I'm going to be joined by four guests who are going to have kind of a fireside chat about some of the big challenges that you all are very aware are facing California as it relates to mental health and substance use disorder issues in our communities. We'll hear from both some county leaders from the region as well as some experts who've been doing research around some of the issues. I think I would just like to mention that California is very unique, and while we will be talking about some of the challenges we're facing, we're really fortunate to live in a state that has made behavioral health and mental health services a major priority for the public. Still, our state is the only one in the nation to have taken a ballot initiative to voters to raise money from taxpayers to ensure we have adequate access to behavioral health. So way back in 2004, California passed Proposition 63, and as you all know, just did a major reform to that in this most recent election with the passage of Prop 1. Our system now of public behavioral health has grown to about a $12 billion system, and that's in large part, I think, about a third of that is attributable to those tax dollars that come from our millionaires. Luckily, we're in a state with plenty of those who help us really build a system of care that is much richer and much broader than most other states. So if you would like to have me welcome our four panelists to the stage. While we're doing that, I'll just quickly introduce in order of who's on the screen here. So we have Martha Crow. She's a research associate at San Diego State University at the Institute for Public Health. Claire Hick, who is a principal at HMA, or the Health Management Associates. Leticia Plancarte Garcia is the local county behavioral health director for Imperial County here in this region, followed by Nadia Pravara Brahms, who's the acting behavioral health director here in San Diego County. Please welcome them to the stage. So, where's the fire? I think I'd like to just start by talking with our county leaders about kind of a popular question that I know we like to talk with our leaders around healthcare, which is, what keeps you up at night? Are there a couple of things that, as a leader of one of the most important and, in some cases, really prominent, even in the news, issue areas, what are some of the things that are really top of mind for the two of you right now?
I'll start. It's more like what doesn't keep us up at night right now. I feel like week to week, it's a different thing. I think a lot of the challenge right now with, the federal stuff happening, so are we going to have funding, or are we going to not? I think for all of the counties, it's a very sort of stressful experience. But I would say also within just the state of California, I think the expectations with new policies versus what counties are actually capable of doing or what they're actually funded to do has been very, very challenging. And I think even getting local leaders to understand, we have a very specific sort of mandate in terms of what we're supposed to be serving as providing specialty care for our Medi-Cal population. And I think there's an expectation that we are sort of the fallback for everybody to receive care, but we are not sustainable to provide that. So the further we sort of expand, the less that we're focused on the population that is most vulnerable that we are charged with caring for.
Great.
I agree with Nadia, and one of the things that has happened over the last few years, there's so many initiatives, so many changes, Care Court, CalAIM. There's a constant change, and the experience that we have, it's also with the pandemic, there was the big resignation, right? We lost a lot of staff. So the state continues for us to push, to do things, to change our system. And that can be very overwhelming. At this point, I can tell you nothing keeps me up at night. I sleep very well. But one of the concerns we have are the recent changes that will be coming to effect in January related to SB 43, which is the change or the expansion of our grave disability, which we expect a big increase in individuals now qualifying for the higher level of care and not having the resources to treat all those individuals. Mm-hmm. So that's a big concern.
Yeah, thank you. I think there have been a lot of major reforms, some of them very narrowly focused on the Medi-Cal program, but things like SB 43, which really are around counties' responsibilities that go back several decades around involuntary treatment and conservatorship. And one thing that most people don't necessarily know is that while counties maintain that responsibility for conservatorship services, they get zero funding from the state or federal government for that. It's a service that really relies on their county board of supervisors to maintain. And so with SB 43 potentially expanding a new population who have a severe substance use disorder, many counties, as they work toward January 1, are nervous about whether that will look like a big new population or not. I think I'm hearing so far that in the counties that went live, they really didn't see the major influx. So fingers crossed that, I think many of those folks come to the attention of law enforcement and other first responders already. And so whether they were appropriate or not to be placed on a hold, they're kind of coming to our emergency departments already today in California. Yes. So what are, on flip side would be some of the things that you're grateful for? Maybe some of them are the things that are also keeping you up at night, like having a lot to do.
I mean, I think the new opportunities for reimbursement are, which we're like sort of up to our eyeballs in and still figuring out. We've transitioned through behavioral health payment reform to a rate-based fee-for-service model, which finally our providers aren't having to track every penny they spend. So I think there's new opportunities in that, and in terms of just overall reimbursement to support expansion and sort of growth of our network. So I think that's one. We've also opted into this BH Connect waiver. So recently we have started billing in our IMDs, which is incredibly helpful for us to make sure that they are able to be reimbursed at a proper rate, but also that it's not a full sort of cost impact to counties. So those have been really huge. I would say the other thing is the workforce. We have a new workforce program called the Elevate Fund, and that's really to address the, I think, ongoing workforce crisis that we all feel in any sort of healthcare. So this program just launched in September, and that's really to grow our behavioral health workforce, and that's through loan forgiveness, tuition reimbursement, stipends for folks as they're getting their clinical hours, and really to encourage folks to get into the behavioral health workforce and support them, and then transitioning into like a county-funded program. So we have a huge array of providers. I think we have over like 350 contracted programs. So it's really, if folks are interested in getting into the workforce, it's sort of our effort to grow the workforce, and we're hoping that it expands to include beyond just specialty care.
Mm-hmm. Great.
For Imperial County, I would say it's similar. Payment reform has impacted all the departments across California. And the other thing that we are very grateful is the opportunities for the grants that have come from the state to really increase our infrastructure, because Imperial County has such limited resources, and many times we rely on seeking assistance in other counties. Having those resources, it's taking time. It's not nothing that's going to happen right away, but at least it's giving us some hope that we will be able to provide a lot of those resources within the county. We have a very good workforce that has remained. Most of our workforce is from Imperial County, born and raised. They understand our population, so they're very committed to what we do. And even when we're short-staffed, we keep moving forward, trying to get all these benefits. We have applied for so many grants, and fortunately, we've been awarded most of them. The other thing to say we're very proud of is our collaboration with some of the partners in San Diego, UCSD. We applied for a residency program, and I think Dr. Ko is here, who has been instrumental in working with us. So we applied to be a sponsoring institution in a psychiatric residency program, and we were accredited this past April with 0 deficiencies throughout the whole process. And I just want to say, having those opportunities to help the workforce. We have also worked very hard in expanding our workforce in Imperial County. We have affiliation agreements with so many universities because with the pandemic, many individuals started looking outside of Imperial County to continue their education. So we are, one of the agencies I can tell you that offers so many opportunities for internships with the hope that individuals will continue their education and remain within Imperial County to serve the community.
Great, thank you. And I think we'll get back to some of the things that you all referenced. But wanted to talk a little bit about the community health needs assessment that was recently done in this region. And one of the things that struck me, because I think in California, a lot of them were kind of obvious findings, right? We know about a lot of the healthcare struggles that people throughout the state have, but something I found pretty interesting in this region was that residents really reported that they're under an extreme amount of chronic and debilitating stress. So while that's maybe not the specialty mental health system sort of thing, but really that kind of chronic ongoing stress because of financial hardship or public health crises. You've got some pretty unique things down here with the sewage crisis we talked about over dinner last night. And I think, people were saying that not only is that affecting their own health, but even their ability to care for others. So what are some of the things that you kind of found interesting around that? And maybe how do you expect that our public behavioral health system or even our hospitals might see those things?
Great. Well, good morning, everyone. I'm Martha from SDSU. And my job up here, I think, today is to really represent community voice. So we went out into the community and we spoke to a lot of people in focus groups and interviews and surveys. And probably most importantly, we had community health workers and promotores out stopping people on the street, outside of Walmarts and at transit stations and all kinds of places to talk to members of the public and to say to them, what are you worried about? What are you worried about with your health? And what do you want hospitals and healthcare systems to do about it? So I feel like I'm here to represent them to all of you. So the first thing is that our primary finding was that people are experiencing unrelenting stress that has been going on for years. And we tend to talk about stress and not really give it the attention that it deserves. It's not just that people are feeling, they're just a little stressed out. It's that they're feeling the kind of stress where they don't know if they will be able to feed their kids the next day. We heard from healthcare providers themselves who told us they're not sure they're going to be able to pay their mortgage or their rent the next month. It is people going into survival mode. Mm-hmm. And they've been in survival mode since the pandemic, and that includes all of you in this room. Right? And being in that kind of situation for years has a direct impact on people's health. And this is what they told us. My health is bad because the stress will not let up. And when I'm that stressed out, I cannot take care of myself and I cannot take care of my family. And I'm sure all of you have felt this, right? Yeah, I would like to go to the doctor, but I do not have time, right? And you all work at hospitals and you still don't have time to go and see the doctor. The people are nodding like, yeah, I'm overdue for my physical, right? All of you. So that was our primary finding, was people just saying to us over and over again, I am so stressed that my health is bad and I don't have the time, the energy, or the wherewithal to get the care that I know I need and that I know my family needs. And I think the most obvious place that you all are probably seeing this, and I'm guessing we're going to get a lot of nods around the room, is in our emergency departments. Yes? So what we found out when we talked to people on the street, about a quarter of the people we talked to had called 911 for a health condition in the last year. A quarter. 2/3 of the people we talked to who wanted to talk to us about health concerns had been to the emergency department in the past year, 2/3. And of those people, most of them had been multiple times. And this was especially true for children, that they had taken their children to the emergency department multiple times. And they also told us that they know that's not where they should be getting their health care. They know that. They don't want to show up at the emergency department, but they don't know what else to do. So they took the time to get an appointment with their doctor about something that's concerning them about their kids. This is especially true for behavioral health, for mental health. But the appointment's 3 months out. And then their child's getting worse and worse and worse. They weren't suicidal, but they knew they were headed in that direction. And then they're ending up in the emergency department because they've got a kid who is, maybe they're out of control, or maybe they just can't get out of bed because they're so depressed. And our emergency departments are not the place for people to be getting this kind of care. That's not what our emergency room doctors and nurses are supposed to be doing. So we're ending up in the emergency room to get care that the emergency room is not equipped to give, right? And even with physical health problems. So they're trying to get appointments, but they end up in the emergency room with situations that might be acute but not emergent. And people from our emergency departments are telling us, well, we're here to save people's lives. That's what emergency departments are for, to treat these life and death situations, but we have people coming up to us and saying, yes, but I'm having an asthma attack, and I don't know what to do, and my appointment's not for a month, and I don't think we should be waiting a month because I see it getting worse. And so that's where they're going to get their care.
And especially in behavioral health.
And especially in behavioral health. We heard a lot about the mental health of people, of their kids, and of their loved ones getting worse and worse and worse, in part because of this chronic stress, right? Anybody who's a parent in this room knows this. The mental health of our young people is absolutely terrible right now. We heard about this especially in the East County. Anybody here from East County? Talking about how worried they are about kids in East County, and they don't know what to do. It's so hard to get into a therapist, whether you have insurance or you don't have insurance. You all know this. You have to, getting in a timely manner is almost impossible. Getting in where the transportation isn't a huge problem, and getting in before people reach that crisis point, it's nearly impossible. That is what we heard. That is what our community said. I want to help my child. I want to help my spouse. I want to help my mom, my dad, whoever it is. And I don't know what to do. It's too hard. It's too hard.
To echo what you're saying, Martha, and I'm Claire Hick. It's nice to meet you all. I'm from Health Management Associates, and I'm from New Orleans. So I came in yesterday, but about half of the work that I do is in California, and love the work we do, especially in Southern California. So you focused on more the community health needs assessment, and that does represent more the people, because you're getting their voices. So when I worked as a hospital CEO in med-surg and behavioral health, we did CHNAs every 3 years or so, and we looked at them and developed a plan and tried to find ways to overcome these obstacles. But when you look at the flip side of it, is how in the world are all of you going to fix something until you have the right resources. So at HMA this year, we had the opportunity and the privilege to partner with HASD&IC, and we did a full behavioral health study. It was one of the most challenging studies that I've done, and that's saying a lot in our team because of one reason. Behavioral health funding has continued to change significantly without necessarily reasoning or understanding in the last 9 months. And so that's challenging for all of you. And I see Dr. Shannon Robinson nodding her head in the back. Shannon worked with me at HMA just recently, joined forces and now works on your team. So congratulations, you got the best asset I felt like we had at our company of 1,000 people. And she lives in your backyard. So what a blessing. Learn from, in our 20-something focus groups, from physicians like Dr. Coe in the back, who you mentioned. Pablo here, had dinner with him last night from Imperial and San Diego. But more than anything, most of you in this room were either part of those focus groups or had one of your direct reports who gave us feedback, who gave us information. We took that data, and then the question we kept hearing from HASD&IC is, okay, well, how do we give a plan to solve these issues? Well, an obvious plan, as you mentioned, is Imperial County has no behavioral health inpatient acute beds. So, but can we dictate that? No. We've got to have the right resources. We've got to have a plan. We've got to develop a great residency program. That is an incredible start. That starts because the workforce shortage in psychiatrists and psychiatric NPs and nurses. And then we look at the challenges from workforce. We look at, okay, California is one of the only states in the nation that says you cannot have intercrossing lines. So as a clinician in Louisiana, I can't give therapy to patients in California, even virtually. Not able to do it in California. Most other states, that's not the case. For example, in Colorado, you can live anywhere in the United States as a therapist or as a physician or as an NP. You can give care, you can prescribe, you can give therapy, and you can be in Louisiana like I am and give care in Colorado. So there's some things that we can change in this room and from that study, and we'll go into it further and later, but there's some things that have to still be advocated on a state level. That yes, California is one of the largest states, but when you look at the challenges, it does have to be looked at locally and at a state level to really make key differences and to meet the community's needs. And to meet your needs as hospital leaders, because how can you be expected to meet the community's needs when the right appropriations are not in place and the right clinical improvements aren't in place for you to be able to do that?
And Claire, in that study, I think, given the work that you do, not only around the state, but even in other parts of the country, were there some things that really struck you about San Diego and Imperial County that were unique? And were there differences between the two and what you all found?
I don't have to tell you the obvious differences. We know that the cost of living in San Diego is significantly higher. That creates a challenge within itself. That creates a challenge within your books. That means the cost of care in San Diego for hospital leaders and others and the patient population. It's higher. You have to look at your water bill and determine if you should not take a shower as long. And you're looking at that in your hospital and going, these variable costs are really tough to manage. So cost containment, looking at the procurement side, what are ways that you can advocate and utilize many of the resources that are ever changing? The key is that it's ever changing. So I will say this, and this is a blessing. At Health Management Associates, we are part of the implementation team for BH Connect. So we have the contract for the whole state. We have resources at our disposal to support, to help, and to implement. And that's one of the key differences that'll happen in 2026, that those resources were not available prior. So certain funding will be available through that, through accreditations, for CapEx, for development, for many things that will affect every single person in this room. But you've got to have the people on your teams dedicated to connect with BH Connect and with those other resources, because if you don't make those connections, you do not have the ability to get the funding.
And so were there any differences between San Diego and Imperial as well to highlight?
There are a tremendous amount of differences. I would say, first, the biggest difference is capacity. If you have to leave your county to get care, that's tough. And that's not just for inpatient, that's for outpatient. That's for most of the most common mental health resources, especially substance use disorder. Now, I will say you guys have some great things in the works that are coming and will I wouldn't say fully support, but it will better support your community. But when you look at where you have to go to receive care, so then we look at San Diego County, we say, okay, well, the population has decreased a little, so that should be good, right? That should mean that we can, in theory, help more people. Not necessarily, because if populations in Riverside have increased and they're coming here for care, if populations in Imperial have still continued to receive care, there are actually 2 hospitals in Orange County who have beds that they dedicate in San Diego County, and they say, you have to reserve these if we're on an overflow. So you're getting competing resources, not just in your counties, but are putting pressure from your neighboring areas. I would say also the geography is significantly different. If it takes more than 45 minutes for a person to get to an appointment, then they may not go receive that ECT care that they desperately need for major depressive disorder, and they may not be able to have the ability to drive and to go and to do. So when we looked at what some capacity issues could be to overcome those key differences, we looked at programs that were virtual, that really made a big difference. Sat next to one of the people last night and talked to her about that now many of the programs, a handful, are open to Medi-Cal. So they are open to doing that now. That's something that's new to meet that capacity demand, but virtual care avoids those emergency departments where it becomes a crisis.
Thank you. And I think in a couple of different instances, different folks on the stage should mention the ability to start to build infrastructure, literally the bricks and mortar of more facilities, more outpatient providers. I think one of the things that we regularly hear from our hospitals is that there are lots of bottlenecks because of that lack of care. So whether that's in the emergency department where people need a service or a bed that's not available, or even once they're admitted into a psychiatric inpatient setting, for example, there's no step down for many people who really, after perhaps 5 to 7 days, are stable enough to be able to go home or return to something in the community, and that doesn't exist. So another area where there's bottlenecks. But I wonder if in San Diego and Imperial, if the two of you might be able to share a little bit about what you're aware through the Behavioral Health Infrastructure Grant Program might be coming to your 2 counties. And while building takes forever, if you guys have a sense of when might some of those new facilities become available, and do we think they are of the type that will kind of allow for some of these bottlenecks to open up?
Certainly. So this is like the very exciting stuff that we're doing right now. So we've applied for over $500 million in grants over the last 4 years. So there's the Prop 1 infrastructure grant, and then we've also, there's several others, including behavioral health bridge housing. So that's to support licensed boarding cares for folks to step down to, as well as this community care expansion. So this was a really unique opportunity that the state offered us. And it's to both sort of renovate licensed boarding care facilities, but also support them in operations if they're sort of projecting that they're going to have likely go out of business because the reimbursement rates are not enough. And so we have, I think we've preserved about 300 licensed boarding care slots, and then we've added about 250 new ones. And again, we did this sort of big study There was that RAND study, I think in 2022, and it was saying more acute beds. And we were like, I don't know if more acute beds is the answer. Like, I think that feels like a symptom of some other problem. So we looked locally and really looked at the very detailed patient data and what the patients sort of, where the bottlenecks are, what the needs are. And we determined that there was just this lack of sort of the lower levels of care for folks to step down to. So this is subacute care, this is licensed boarding cares, and sort of services like that. So we have taken a very, very sort of accelerated approach to pursuing all the state grant funds that we can to like build those out in the most immediate sense. And then for Prop 1, so we applied for 2 and we're awarded 2 programs. So we're going to be building we're renovating currently in National City a substance use treatment facility. So that I'm not sure the timing. I think that's going to be next year that it'll be finished. And then we're also going to be building a children's crisis residential program in San Diego. And that's going to be, I think it's the first of its kind in the state. It's a 16-bed facility. And then we have several community providers that were awarded grant funds. So we're already in talks with them, including a PRTF, and I always forget, psychiatric residential treatment facility in San Marcos. So we'll be working with them on that, and then some other providers that were awarded. So it's like across the region, we're doing a lot of work to really establish new infrastructure. And then most recently, our board approved us to apply for, and we just submitted our application in October for our behavioral health wellness campus. And this will be for folks from San Diego that are familiar with the psychiatric hospital, the county psych hospital. There's a building adjacent to it that is coming down, and we are going to build a wellness campus. We applied for $100 million, and then the county will fund $100 million. So fingers crossed that we get that. And that's going to be an entire continuum of care. So it's going to have subacute care, it's going to have mental health outpatient, SUD residential, it's going to have peer crisis respite, and one more, and I can't remember, but it's going to essentially crisis stabilization. So folks coming out will have, we can do a warm handoff, walk them across the campus to the service that they need. And so we're really excited sort of just to continue that. But I want to note, while there is a lot of money, and this is sort of like once in a lifetime, we're catching up for 50 years of lack of investment. So I think for most folks, it feels like, oh, this money, we could probably do 10 times over and still not have enough. And so while we're very sort of appreciative of that, we still need more infrastructure, and we still need then reimbursement that goes along with it, so we can pay our workforce, so we can pay our hospitals, so we can pay our providers in a way where the care is good, that they don't have this like turnover and churn of workforce, and that we have facilities that folks are encouraged to come in that are close to where they live, and so they want to seek treatment.
Mm-hmm. Thank you. And Leticia, what about in Imperial County?
I'm so excited to hear everything she's doing in San Diego. We're doing a lot, and I think it's at a smaller scale based on the needs of our community. Again, we've done also a lot of, look at where the gaps are, what the needs are of our community. And one of the things I want to say, Patrick is here from API. He was one of the first that came in and assisted in establishing a crisis residential facility in Imperial County. So that has been of great assistance for us. As far as the new grants, we have also applied for the BCHIP grants, rounds 4 and 5. In Imperial County, we have developed a lot of programs because of the limited resources. We have developed a lot of school-based programs, our wellness centers, to provide all those supports that individuals need. But like Tanya said, the infrastructure for bigger projects has been very difficult, especially for a county that cannot invest in behavioral health facilities. I started in a clinic that used to be a hotel. We call it the old hotel. And this was built like in 43. The county obtained it in the 70s. And it has been the children's clinic for many years. It's a beautiful clinic. It looks like an hacienda with a quad, trees. Kids love it there. You see them climbing trees and we have to chase them. But the county has never been able to invest because it used to be a hotel. It still had some showers that were being used for storage. And the solution was, let's tear it down and make parking lot. And I started working there many years ago. So I've been advocating for not demolishing that facility because it's centralized. It gives a lot of access to the community that can walk to that facility. So we applied for round 4 and we were awarded. And the length of time to get things done, it was like 2 years ago. Construction barely started on the 17th because of all the processes, but it's getting done. The other thing that we saw with the pandemic was a significant increase of youth seeking services and coming to our crisis desk. That was our second grant that we requested, and it was approved also for the expansion of our triage unit to increase the number of beds for youth. Because we don't have a hospital in Imperial County, this triage unit is where we hold individuals on a 5150 involuntary hold, and then we coordinate the transportation to out-of-county hospitals. So that was approved. And the other thing that we're very proud, and Gabby's here, who has worked, so hard to bring the first, I hope I say it right, adult substance use residential facility to Imperial County. Again, we just started. Everything has been approved. We're hoping that this will open in 2030. Again, 2027. 27. So again, it's all the work that goes behind this. And under the change with Prop 1, the Bond 1, we also applied for the expansion of services in our North End. As you mentioned, in Imperial County, and the things that we saw in the report is that the North End has some of the most significant problems with substance use, overdose, and death by substance use. But it's also one of the community where we have struggled the most to increase services. We were awarded, and it's been a challenge for the community to accept it. So we're going to the board, hoping that they will support us accepting the funds in January. But I can tell you, we're dealing with very conservative populations that it's not in my backyard, even after getting the 22 millions to develop and expand those services in the North End. It's very difficult. Mm-hmm. So we've been getting a lot of support from a lot of the players, but then again, we're dealing with some key players in that community. We also recently applied for the other round 1 under the bond for developing a campus model. And the county has been providing the land for Imperial to expand these facilities. So again, this is where we want to expand. Again, to have a centralized location, like Tanya was saying, we want to have a more seamless process for individuals where they don't feel that services are fragmented, that if they come on a crisis, they can easily get the assistance they need right away the next day, or that we're able to walk them through the process. So we're proposing a peer respite facility so that we can enhance what we're doing and move in the same direction that the state wants us to move. Mm-hmm. So it's exciting. We have also taken advantage of a lot of things that other grants that the SAMHSA, which has been a very good project that we developed a few years ago that has been so helpful. And this is something that we want to hopefully replicate in other areas of the county because of access. We developed what we call a Casa Serena. And this, it's a small facility right now where the hope is to increase it. But it has therapeutic rooms where people can just walk in. Whether they're a client or not a client, people can come in, relax, ask for help. And it has been such a positive impact in our communities that law enforcement and other community partners are now referring to this. We hear about it all the time because people don't feel like they need to come, how can I say, for an appointment, even though they get the services right away, they get seen right away, they get linked to medication, to whatever they need. Many of the things that we address at this facility, it's the food insecurity, the housing, and we're able to provide that right away and prevent individuals from going into a higher level of care. So it's been an amazing project that we didn't expect to have such a positive acceptance in the community. We also received some grants to start our mobile units. Again, that's also something we've been working closely with law enforcement, and we've received very good. Before we were always fighting with law enforcement. Who's doing that and who's doing it. Now our relationship has significantly improved. And because of our geographic composition, we are big rural area. We also purchased a specialized unit with grant funds that we're able to deploy. This mobile unit has 2 offices equipped with telehealth. Individuals can get services in the field. If you're familiar with the labs, we go to the labs, we go to Calipat, some of the remote locations. Part of it is to increase the awareness, a lot of outreach, but also provide the immediate intervention. If a crisis arises, we're able to transport individuals with another team that goes with our mobile unit to get them the immediate help that they need.
Thank you. I think one of the things that we started out by talking, I think, Nadia, you mentioned one of the things keeping you up at night is a lot of the federal uncertainty, not only uncertainty, but just bad news, frankly, that we're all kind of bracing ourselves for, especially in the hospital emergency department space, expecting to see a lot more uninsured individuals throughout our state. One thing I think was a recent learning for me that was sort of a relief was that one of the major changes that our federal legislation, H.R. 1, makes to the Medicaid program is to impose work requirements. And was pleased to see that one of the things that's in there are actually quite a few exemptions for individuals to not have to lose coverage if they are not able to participate in the work requirements piece, and that for the most part, the county behavioral health population is exempt. So we hope that that will be helpful, but there still are the unsatisfactory immigration status kind of rules and the kind of more regular redetermination of Medi-Cal eligibility that we expect other folks will be falling off of the program. Have you all kind of looked at, in your own counties, is there any way to estimate among people with a serious mental illness or who are in substance use disorder treatment with Medicaid who you are worried may lose their coverage despite being exempt from the work requirements?
So I don't think we have numbers. I know our self-sufficiency team has been like, this is like their front and center, the most important thing they are doing in terms of what the impact is going to be to behavioral health. First of all, I have to say, when this came out, we had immediate outreach from our providers in terms of like, how can we help make sure when somebody's on an appointment that they're getting re-enrolled and doing it. So I would just have to credit them with like the sort of mission to keep people enrolled in Medi-Cal. And I thought that was just a really, like we want to wrap around folks and like whatever can make it easier for them to stay connected. That's what we want to do. We don't have like specific, I think this is going to be, I think all of these it's like changing behavior. And now this is going to be a change in the behavior of people. Like, are they going to come re-enroll, and how easy is that going to be? And is this sort of, I don't know if it's a plan to have people fall off, but that's sort of what it feels like. We don't concretely know, but I will say we are certainly planning, and having discussions about sort of like how we would keep people enrolled while we figure that out to make sure that folks are continued to connect to care. Because I think all of us know that having folks drop off is going to not serve anybody well. And I think a lot of the complex issues that we're seeing are only going to be exacerbated if we don't continue care.
And to echo what you're saying too, when I look at from your perspective as a hospital leader, I'm going to look at, okay, well, I only have this many days of cash on hand. That's just a big thing. As a leader, you have to evaluate continually. Well, if I'm going to have to count on retro authorizations, which will be a lot of majority of claims that will start happening, if it's not already starting, you'll see it more is what our analysis shows. And those retro authorizations, as we all know, can even be denied. So you thought that you've given the care, you've done the work, you've treated the patients, whether in the emergency department in your hospitals or in the inpatient side or even in the outpatient side. But having the retro authorizations means that that care payment is at risk. So I would say what you're doing anytime they're already coming to an appointment, going ahead and trying to be proactive, that's really good. That's where it needs to start. Where it's also going to start is with every single leader in this room who run hospitals. You're going to have to realize that retro authorizations will be a reality as people do drop off, and that coverage of the care you gave, the money you spent, the clinicians who provided the care, keeping those clinicians, and that's going to just be a risk.
Yeah. I think one of the other kind of good news areas, though, is the opportunity for you all to be doing planning for the next several years. Of course, in the face of all these newer changes that no one necessarily expected or could have predicted. But with the passage of Proposition 1, as many of you know, each county is now required to put together a new 3-year integrated plan. And they're calling it an integrated plan because the sort of what's new about this planning effort is that it includes really every dollar that each county behavioral health system gets, not just the millionaire's tax from Prop 1 or Prop 63, but also includes substance use disorder issues and an expectation that you're trying to find a way to ensure that you're maximizing all of those different dollars to meet not just mental health and substance use disorder issues in your community. What are some things that you think hospitals should know about having a voice in that process? And do you feel like there might be things that hospitals, whether that's the emergency department again, or in our general acute care work, or even in patient psych, where maybe we have data or knowledge about what's working, what's not, that would be helpful for your local community planning process?
So our planning process is happening right now. We are doing, since I think September, first of all, state guidance for this was very delayed. So we are like scrambling now. But there's a lot more requirements for who's being engaged. So that process is going on right now. So for everybody that's not super aware, this is Prop 1. This is like, we had the Mental Health Services Act. It will now on July 1st switch to the Behavioral Health Services Act. It changes the sort of fundamental programming components. So I think a couple things that I think have been very concerning to us, but I feel like are now becoming concerning to other folks as things are changing. The local prevention funds are being eliminated. They are being shifted to the state. So as a result, this means a lot of prevention programs locally funded through county behavioral health agencies are being eliminated. And I think that is, folks are kind of surprised or shocked by that. This was something we, from the very beginning, had major concerns about, and now it's happening. So I think that's one sort of key thing. A majority, though, of the things funded by the Mental Health Services Act will shift over. So I don't think we're going to see drastic changes. We will continue to fund sort of our core services that are, reimbursable through Medi-Cal. I think one of the big, our full service partnership, assertive community treatment programs. Those are like the highest level of outpatient care for the most acute folks. There's going to be also an emphasis on housing. So I think this is, as Prop 1 was sort of being talked about, I think at the state level, there was a heavy emphasis on housing. I will say that locally, the nature of this is we already do a lot of housing as a behavioral health agency and have been for quite a long time. there's not, in my opinion, as we're looking at the numbers and what's available, there's not going to be a huge significant shift in housing. It's just sort of like rearranging the components, moving the things over. We are going to be starting the transitional rent benefit, though, in partnership with the managed care plans, which is very exciting. And that starts January 1st. Our board voted on Tuesday, actually, to sort of enter into an agreement with agency called Brilliant Corners, and they are going to be providing the first, through a flexible housing pool, providing housing, transitional housing to folks with serious mental illness and substance use disorder. And then through Behavioral Health Services Act, we'll be funding the second 6 months. So this is very exciting. This is, in terms of like sort of the evolution of reimbursement, it's going to fund, it's federal funding to support transitional housing for people as they're connected to care. So we are really, really excited about that. I think that is we're doing a pilot, and I think that will be a sort of huge new thing that we hope. We're starting small, and then, we're going to work with the state consultant who's going to help with technical assistance to grow that.
Great.
And in Imperial County, we also are currently in the process of obtaining stakeholder feedback. We contracted with HMA to be the agency that it's doing all the meetings, the key informant interviews, community focus groups. Like Tanya said, we provided all of our contact information, all the partners that needed to provide their feedback so that we could develop a program that it's really based on the community, based on what the partner agencies are telling us we need to focus our efforts. One of the things, and we've been having meetings with them, it continues to be the theme for Imperial County, the importance of access, having a more seamless process for individuals coming and receiving services. A big focus is on youth. For us, it's a little bit different. We've been working, before we contracted out more stuff for prevention care to some of the local providers. So we've been working with them in preparing them that we will no longer be the ones responsible for the prevention side. But we're also looking at how we're gonna, allocate within Imperial County some of the funding to continue some of the programs that we feel are really making a difference, that it's important that we are the ones doing some of the prevention and early intervention work. For us, housing, it's a big challenge because there are housing limitations, and we have really never done a big investment on housing, again, because the allocation for Imperial County for those big projects has been a lot less than what a larger county gets. So for us to invest in apartments or housing projects, it's been very different. So we are working with some agencies that will be working with us to see how we can comply with that portion of the new BHSA program related to housing.
Is Imperial a small county, under 200,000?
Yes, we're at 180. When you compare us to San Diego, as far as geographic area, we are almost the same size, but population is significantly very different. Yeah. We're only 180 in population, small cities, 35,000, 45,000, and then we have a lot of very small towns.
And that correlates with funding.
Mm-hmm. Yes.
Yeah.
I think in the BHSA, right, aren't there some flexibilities for small counties that you can ask the state for? I think, for example, on housing, there are some opportunities, I think, for counties that are small to say, look, we can't possibly direct a third of our money or, the way that some of the larger counties are. Do you expect Imperial to maybe pursue some of those options?
I can tell you initially we said, yeah, we're going to go for that exception. But now we're waiting to see the feedback that we get from the stakeholder and see where we really need to invest. And it may be a partial exception. We still don't know. We're waiting for all the results and in order to make decisions.
Gotcha. Okay. One of the other things I think you maybe you've already partially answered this, but wanted to give you the opportunity to share. It can be confusing for the public that's following the news about what the Board of Supervisors is saying or what county leaders are saying around the kind of the financial distress that county government is under right now. Can you kind of give us your sense of kind of what's the latest in each of your counties about kind of county government financial well-being, and is there something specific that you can say about kind of the county behavioral health department's budget, since thankfully in most cases a lot of those funding streams are directed to specific behavioral health services?
Yeah, so I think, the struggle is real. I think it's, for counties, it is a challenge. I think there's, from the county perspective, everybody's fighting for the local revenue, and what we're sort of trying to do as the behavioral health agency is pursue all the other opportunities. I want to be, my goal is to be not dependent at all on local funds and utilize all the other different sort of funding sources to be sort of a self-sustaining department. So that's the realignment funding, which is for mental health, behavioral health. And then this is also pursuing all of the other opportunities through BH Connect, which is this waiver where we are starting to bill for other services and some additional services that we there's new requirements and new EBPs that we have to put into place, and then we'll be able to bill for those. We have already been doing a lot of those and already meet the requirements. So for us, it's not going to be terribly difficult, but there are some new ones. I think as a behavioral health agency, will continue to grow. Our projections through the implementation of payment reform and making adjustments related to that, and then again, being able to opt into some of these things where now there's reimbursement for them. I anticipate next fiscal year that behavioral health services as a county department will be increasing. The other thing is just, like the needs for different kind of expertise and staffing. So billing is going to be very important for us. And so, making sure that we lean into that, because man, the ROI for that is, if we can do this well and support our network and doing it well, it is a significant financial benefit both for us and for all of our providers. So leaning into sort of those opportunities so we can get really good at that. So I think for behavioral health agencies, who knows? The feds could make a decision tomorrow and this all goes out the window. But I think right now we're feeling pretty good. I would say one other thing. So we advocated, and many of the hospitals here today who provide behavioral health care were sort of the beneficiaries. About 2 years ago, there was a state plan amendment to allow for sort of relooking at the way hospitals are reimbursed for inpatient services. And we were one of the first counties to go after that and really continue hammering the state to make sure that this is put in place. And that was successful. And we've now been able to align rates. They're still not where they should be, but very significantly increased to align with actual costs for inpatient services in hospitals. And I think that, to me, again, is another, it's reimbursable, it's sustainable, and now, sort of everybody's going to benefit from that.
And to have a leader to be able to do it, I've worked in about half of the counties in California. That's just not common for someone sitting in your seat to advocate always in every single way for those reimbursable rates to be fair. So I just want to commend you as a leader for doing that, because you're able to help every single leader in this room keep their lights on, and to hopefully help sustain the services they have. Because if a service line like behavioral health, inpatient or outpatient, continues to not perform where you need it to be, it is at risk. And so making that, advocating for the right thing, even though it's hard, I just want to commend you for doing that.
Yeah, and I think we've seen locally, we had 2 inpatient, we had North County, and then several of them closed because if they can't afford to operate, why would they do that?
Right.
So I think from us, it's also this risk of loss of capacity that we know we need, and that's the right thing. folks should get
Right
paid
thing.
for the work that they're doing. It shouldn't be like, you're running on a shoestring budget to provide something that's very expensive. It's just not, like the math isn't mathing on that for anybody.
And part of our report, we advocated even a step further for hospitals. We said we need it to be studied further related to denied days. Were the denied days related to not having that step-down care built yet? And it's under construction and coming, but how can you as hospital leaders, you're carrying the burden. And at what point do we look at it and say, how should this be further evaluated? Well, one way it can be further helped is by adding the additional step-down resources, which those are coming, and that's good. In the meantime, what does that look like, and should that be studied further to carry that burden with you to support?
And can they be reimbursable at some
And
point?
can they be
Yeah.
reimbursable? Because if you're giving the care and you're still required to give the care, and you can't, on a risk management side, you're not allowed to release those patients, then where does that balance, and how do we make it sustainable?
Before we open it up to Q&A, I kind of wanted to circle back to you and some of the things that you found in the community health needs assessment. There were some ways where I think the folks you talked to, while you talked a lot about how we're kind of inappropriately using emergency departments because people aren't able to get access to care out in the community, but they did say that when I do show up for healthcare, I want a different experience. Can you talk a little bit about some of your findings around kind of the hospital experience and recommendations that kind of came out of your needs assessment?
Absolutely. So at a very much more granular level, I'd love to share with you some of the things that I think that our community has asked us as the privileged people sitting in this room to do to help minimize trauma, which has a direct line to behavioral health. So the first thing that I want to say, because there's a lot of people in this room who are very powerful and influential, is the community knows you are. And they want to see you flexing your muscles and advocating for better care for them, and they want to see you in the community. We heard a lot about the flooding in South San Diego and Southeast San Diego. Y'all nodding your head, some of you have heard of this. People had to beg for medical supplies. They want the hospitals and the healthcare systems there when they're in crisis, right? They want the data tracked. We have no idea how many people got sick. We have no idea how many people died. We have no idea. Nobody was collecting that data. So as a university, I know my department chair is here somewhere. We have to do a better job of tracking that data. These are the things the community was saying. Within the hospitals, they had really great, simple solutions that are not infrastructure or big, huge things that need to happen to minimize trauma. They want every person who comes into the room to introduce themselves, to tell them their names, and to say why they're there.
Aid it, as we call that in hospitals.
Just to say, hello, I'm your medical assistant. This is my name, and this is why I'm here. They don't want to have to repeat their stories over and over again. They would very much like an acknowledgement of the systemic racism that happens in our medical systems. It's not something that people like to talk about, but it causes people trauma in our hospitals and in our healthcare systems, and they'd like our leadership to be talking about it, to be acknowledging it, and to be making a plan to address it. I heard a story from one woman who is a nurse practitioner, advanced practice clinician, who went in to get imaging because she had felt a golf ball-sized lump in her breast. And the person who was helping her said she couldn't feel it and she couldn't see it on imaging. And so the nurse practitioner was showing her where it was. She spent all day there, and she said she was brought to tears because no one would listen to her. And she ended up having 13 fibroadenomas. I don't know if we have any breast people in this room, right? But she had a lot of trouble, and she said she was in tears, and then people got mad at her because she was advocating for herself. This kind of stuff is happening all the time, and we have a lot of infrastructure and funding issues that I don't know a lot about that we need to address. But we also need to be hearing our community and being out there in our community and saying we are here for you and we see what's happening. And when your house floods, we're not going to send you to Temecula for your emergency shelter 50 miles away from where you live. We're not going to make the nonprofits go and beg for supplies to take care of these people. We need our leadership to know not just what is happening at the federal level or at the state level, but what is happening down in our communities, and especially when we're talking about South San Diego, Southeast San Diego, the Tijuana riverbed crisis, which I know we're going to talk a lot about today. People feel like they have been forgotten. But I also want to say, on a much more hopeful note, that the other thing the community said to us is that they're so grateful for their providers. Mm-hmm. When we asked them, what do you want us to tell the hospitals and healthcare systems? They told us over and over again, please tell them I said thank you. I know how hard their jobs are. I see the pressure they're under and the stress that they're facing. And I want them to know that I see that. And I am grateful for that. And go tell those CEOs to take care of the people working in the hospitals. Tell them to do a better job with the people who are taking care of me, because I know that they want to take care of me. I see it, and I know that they can't. So there was both a lot of gratitude and a lot of frustration that people feel ignored and abandoned.
Thank you. I think we do have other things that we can talk about, but I want to make sure, because we've got such a big room today and you have an opportunity to get individual questions answered. I think we have the ability to drag some mics around the room, but if folks would like to just raise their hand and we'll come find you.
Hey, how are you?
I'm great. How are you? Yeah, thank you so much to the panel. Great information, very informational. My name is Connie Lafuente. I work for the community colleges. And one of the comments was that as you are looking to expand behavioral health services, you will also have the need for more workforce. So my question is, how can we, at the community colleges or education entities, partner now so when that time comes, students are ready to take on those jobs?
I want to say that in Imperial County, we work closely with our local community college, and we're always doing presentations, going and asking, and we offer to have the students come to our facility to complete their hours. Same thing for our master's programs. We have been, again, being very open and more than willing to work with all the educational facilities. Now San Diego State in Imperial County brought the bachelor's in nursing program. So we work very closely with all the educational facilities to offer, the opportunity to complete hours and their field experience within behavioral health. And that has been very helpful. With the master's program, now we have individuals requesting to be placed at behavioral health as part of the practicum. And again, as one of the things that we've seen is the shortage that we had for some of the very important clinical positions are being filled. One of the things we want in Imperial County is for cohorts to be more frequent. Sometimes we have to be waiting 3 years for a new cohort of MSWs, and sometimes, now it's not just Imperial County that hires a therapist. It's schools, hospitals. So the number of people that graduate, it's not enough to fill the needs within the county for everyone that's hiring those positions, and nursing staff.
And to answer your question just in the most direct way, our request would be that don't just start, when they're 18 years old or deciding what they want to do, or if they're 40. Start when they're in 9th or 10th grade. If you can do that dual enrollment. I know in about half of the states where HMA works, we're seeing dual enrollment where students are graduating from high school with an LVN, or with even an RN. So, and have half of their credits done to become, for social work now, it does require a master's level typically, so that's just the beginning. But the work that you could do and that you're probably already doing, expanding that, because so many students I talk to when enrolls, they say, I just don't know what I want to do. And I said, then try healthcare. we need it. Our aging population, our hospitals, we need you in some way. Start your community college in 10th grade and allow those enrollments as dual enrollment, because if they can get that taste of what they like and those classes underway in a setting where it can be less stressful when they're still living at home, they are highly more likely to help every single leader in this room and to help take care of all of us.
And I would maybe add, because we've talked to our members as well about what their unique workforce challenges are for folks doing behavioral health in hospital settings. And I think in the public behavioral health system as well, there's been sort of this longstanding agreement that we aren't necessarily doing the best on the content sometimes of what folks are learning to prepare them to work with the clients who are really the most vulnerable, whose symptoms include psychosis in particular. A lot of what folks learn in kind of mental health curriculum stays on the sort of depression, anxiety, suicidal issues, which, may be more common, but really that most acute population that the counties are really focused on, many of whom have psychotic disorders like schizophrenia. A lot of clinicians don't necessarily leave having spent as much time as I think our system really needs people to have that expertise. And then I would also say that in terms of folks having the opportunity to do on-site or clinical, experiences while they're in school, having them have placements in psychiatric inpatient settings would also be something that I think our hospitals have said. We have folks who come out of an MSW program or a bachelor's program, think they want to work in mental health, and then they go to a psychiatric hospital for the first time, really, and realize, oh, whoa, this is a whole other part of care delivery that I had no idea. I don't know if this is really for me, but that's their first exposure.
And I would just add, through our, we're doing this Elevate Behavioral Health Fund, and there's a website for that. So anybody interested, we're working with the community colleges, but we're also doing placements for folks to get their clinical hours with our community providers. So I know there was a number, it fills sort of two needs, both the provider is able to train folks and potentially keep them then long-term, but also just bringing in additional workforce to our entire continuum. So there's a lot of opportunities there that I would recommend sending forward to your students who are interested in sort of a longer term trajectory in that.
Great. I have another question.
Yeah, hi. Steve Kum, a psychiatrist at UCSD. How are you guys? So I think I have a comment and a question. So the comment is really addressed to all the audience members. And I got to tell you, we all work in an imperfect system. I think we all recognize that. And I think all of us are doing our best to ensure we provide the best care in our hospitals and the EDs. And I've seen CEOs, COOs, CFOs go through the EDs and the hospitals saying hi to folks and doing everything we possibly can. And I think everybody here should be quite proud of the work that all of you are doing. And this is coming from a physician, right? And I've seen C-suite folks and the administrators walk the floors with us. And so I applaud all of you guys for being here and doing the work that you do. So that's my comment to all of you. My question to the panel has to do with, as a researcher myself, quite frankly, I'm a little bit tired of continuously hearing about we need to do more research. We know the problem, right? We've done MHSA for 20 plus years. Everyone agrees that there's been some issues with it. But instead of looking at the programs that's gone on for the last 20 years, we decided to upend the model with no clear pathway forward to fix the problems that MHSA sort of tried to fix, right? So my question is, as this 2026 date is approaching us, right, what lessons have we learned from MHSA, and where do we go to ensure that the mistakes from that era doesn't get repeated 20 years from now, right? Because 20 years from now, when I'm retiring, hopefully, assuming my wife lets me retire, right? So when that happens, I like to be able to tell them, look, we did this thing, okay? And there were some mistakes that were made, but it's not the same mistakes that we made 20 years prior to it, right? So I want to be able to say that. So my question is, instead of saying we need to do more research on this, like, what are we going to do differently to fix the problems that we identified from the last 20 years?
That's a big question.
It is.
Thanks, Dr. Ko. So, part of it for me is just we need consistency. I think, from a behavioral health standpoint, we are a specialty care system. If folks are coming to us, they're already at a very acute level. I think the prevention side is where we need to focus. So we don't want to see folks. There's folks that we're always going to see, but we don't want a ton of folks coming in and then figuring out how are we going to make everybody better? We want we are sort of the last resort. So I think that's there's prevention. I feel just isn't as sexy, because if it's working, you're not sort of seeing the result for us is we're serving less people, hopefully. I would say, so I've worked with specifically MHSA for a decade now. I think most of the programs, I would say 95%, have been tremendously impactful. This is things like ACT services. This is their school-based programs, are now crisis stabilization units. They're all things that, had we not had that funding, they just wouldn't exist, or would be very, very small footprint. So I think California doing that and allowing us this revenue source to be able to actually do all these services is something that's incredibly important. I think the challenge is everybody wants a quick fix to a complex problem. So I think we've heard it over and over again. We're driving around downtown and there's people on the street who are acutely sick and homeless. So changing MHSA to BHSA is going to hopefully solve that. It is not going to solve that. We have a lack of housing inventory. We have, we could do tenfold, again, like I mentioned, tenfold the services we do, and we probably still won't have enough to serve everybody. The other thing is individuals have rights. So if they don't want to engage, you can't make them do that. So I think there's this, it's so complicated. I think BHSA, there's going to be some good pieces of it. We're excited for this transitional rent thing. But I think in terms of the way it's framed, that it's going to be significantly changing what we're seeing as we, sort of drive around. Those are two different things. It's going to help some of it. But it's not going to fix that problem. And I think, it's not a county thing to fix. It's not a UCSD thing to fix. It's not one, until we recognize that housing is health, I think as an entire community, and everybody's working together, and then there's reimbursement that will support that, I think this problem is going to continue.
And I think you can, when you look at Dr. Ko, you and I have talked about this even in some of the focus groups that you were in and gave incredible insights. If you look at 10 years ago versus 10 years from now, you have to quantify it. You have to say, did behavioral health patients in all of your emergency departments receive care in a time frame that you feel like, and probably the patient feels like, was acceptable? And if you can say yes, that they were placed where they needed to be, or they could be referred for services, within that certain time frame of minutes, then that's a quantifiable win. That's the way to measure it. To answer your question, in 20 years or even in 10 years, how do we determine if what we're building, what we're doing, what we're planning right now is right and made a difference? It's looking in your hospitals. It's looking in the respite, peer support. It's saying, we created all of these things as a pilot. We saw it worked well. You guys did a great pilot. It has worked well. It's already been able to be quantifiable, where people are receiving resources same day instead of in 3 months. So when I say, my answer would be, Dr. Steve Ko, I would say, what we're doing right now able to be measured and able in your hospitals to better support you? And if the answer is yes, then I would say those are the things that we say we continue, that are wins, and we continue to make adjustments and give feedback to our counties and do that together.
And one of the things I want to add, when MHSA came out, it's like counties were told, oh, you can create the system that works for your county. without really providing any measurement. Everyone developed programs that work for their county. As of today, MHSA has never done an audit to know what has worked. And they just ask for more and more information, but we have never really said, this is what works. I can tell you from what we implemented, what are the programs that we see that are giving us good outcomes in our community, and those are the programs that we want to continue under MHSA, BHSA. And like you mentioned, we won't know. And again, because every county is developing their individual program with more specific target populations now. And they had given us to us under MHSA, but again, nothing was standardized to say what's working. Let's give a report on this. All of our reports every year were posted without any feedback. It's working, not working. So I think that now they want to put more accountability on the counties. And I think that's what we're going to need to see. You know, what are they going to do? How are they going to measure for us to provide those outcomes? Because that should be the focus. How are we making our system better? And how are we going to, make it more seamless and more integrated using all these different funding structures?
I would also add that if we had a few extra square footage to extend the stage, we could have other payers up here who really did not have a role to play 20 years ago. We passed Proposition 63. County behavioral health was the only game in town, unless you could pull out a paycheck and pay for a therapist, right? So now, in our state, through the Affordable Care Act, but even in our own state legislation, SB 855, really anyone with any type of insurance has a long list of benefits. I just recently looked at my own EOC when I switched health plans and saw Care Act mentioned, saw mobile crisis, saw, no prior authorization for anything I might get if it's referred to me through 988. So, I think the other acknowledgement is whether it's prevention or early intervention, that all of the things that, used to really be only county and MHSA funded things, we have a whole other set of payers, whether that's commercial plans or the Medi-Cal managed care plans, that have a really important role to play and could also be on the stage here today if we were going to talk about behavioral health.
Can I add one more thing too? It also gave us the opportunity to develop these new programs as diversionary programs. So like mobile crisis teams and our CSUs, folks don't have to go to the ED. Now they can be transported, if it's a behavioral health crisis, to one of our 6 CSUs countywide. We have seen in our psych hospital, since the implementation of the CSUs and the mobile crisis teams, a reduction 40%, almost 40% in admissions. So I think for us, it's not, sort of it's like avoidance of something, and they get better care and they get connected more timely to the care that they need versus going and sitting in an ED where somebody might not have the expertise to do it and they're, might not be connected long term. So I think there's a lot of things that we were able to sort of pilot utilizing MHSA that we're going to carry over to that really affects the entire community, and not using law enforcement in a way where they shouldn't be involved, and maybe somebody doesn't want them. It's sort of getting the right folks connected to the right things.
To me, one of the changes that we've seen with MHSA, it's all the outreach, because that was a big key in the prevention. It was really an effort to reduce the stigma. And even though we continue to experience it, we've seen a significant change. And I think that goes with the amount of the demand, the increase in caseload. People are more willing to say, I have mental health issues. We support some of the school-based programs. And many times it's something you wouldn't have seen before, where kids are saying, hey, that's my doctor or that's my therapist, very open. And to me, that has been huge as far as what MHSA did. It gave us the opportunity to be out there in the community, to partner with schools, with different care providers, just say, it's okay to not be okay, right? And just kids, just the conversations that they have now about mental health is significant. And yes, we still have stigma. I'm not saying it's gone, but there's been a big change in how we talk about mental health. And I think it was a result of all this funding that came to counties for that prevention and early intervention.
Over here.
Yes, and. We've talked a lot about the findings and the challenges we have in our counties, but one of the things that I want to flag that hasn't come up here is the Office of Healthcare Affordability and the state's efforts to cap costs, but then also address the behavioral health continuum. And one of the things that is carved out is this concept of investments in behavioral health. However, the Office of Healthcare Affordability has defined the investments in behavioral health as not inpatient psych. So I think it's really important to raise that with this group and hear and uplift what you are finding and hearing with that office, because otherwise hospitals are not going to be able to continue to invest in inpatient psych. And what we're seeing with the fewer beds is going to continue, because while outpatient is important, the inpatient is also important. And want to make sure that, like you're saying about the MHSA reports, that this information doesn't stop here, because there are other agencies that play in this space. And the findings of the CHNA are not just lifted up by the hospital community, but all of the community saying, we've identified this as a need here, and you, state, need to hear us out about those investments as well.
Thanks, Ellie. Any other questions?
Yeah,
Way up here in the front.
I'll get
I saw you wore tennis shoes, so
I
that's
did.
helpful.
I knew better.
You can just step
And this
in
will
today.
probably be our last question for the break.
Hi. Yes, my question is for Martha. One of the things that I heard you say, which is very concerning, is when, you talked about the stress that, the community is going through, and them being very concerned with, the access to care and having to wait 3 months. And for Imperial County, as we've talked, there's limited resources when it comes to some of the things that we have to depend out of county for behavioral health services, but then also on the medical field and other areas such as, services for autism, where they're also dealing with a lot of staff turnover and maybe limited staffing that can lead to that. But one of the things for county behavioral health departments is, the timeliness standards that we have to ensure that we serve people on time, and that there's that access to care, which is, being able to provide them with an appointment and an admission within 10 days, or, seeing a psychiatrist from the time that they request that service within 10 days. And so when we're looking at our timeliness standards data and reports, we see that we're meeting that timeliness standard, where anyone that's coming into our services is actually receiving that care in that specialized, either specialty mental health service or substance use treatment within that period of time. And we've built a lot of other resources to ensure that we're meeting in making sure that access to care is available to individuals, such as, our mobile crisis units, low barrier clinics, such as, as Leti mentioned, our Casa Serena, where they can walk in, and even transportation services because of what we spoke about, our geographical area in Imperial County and people not having access sometimes to transportation. So all of those elements, in addition to many more, to ensure that access to care. But one of the things that we continue to see, even, when you mention that report, and even through our community planning process for BHSA transformation, is this perception that the community has where, well, in order for me to get an appointment, it takes me 3 months, or I can't get an appointment soon enough. Even with all of those efforts, outreach, we even have a radio show. We have, these ads where we're telling people. So my question to you would be, since you've been, working with the community, you get to hear them out. What would be your recommendation to maybe see, how do we, even with all the efforts of letting the community know that this service is accessible, what else would you recommend that maybe we need to be looking at to make sure that people you do understand that services are there and accessible in a timely manner for them? And if there is an urgent condition that we need to address, we would do it right away and serve them as they need.
I think my number one suggestion would be that when someone calls for an appointment, let's say I'm a patient of, I don't really want to, who should I pick on? Scripps, because that's where I go. Sorry, Scripps. I call Scripps and I say, I'd like an appointment for my daughter because I think she's depressed or anxious. We need the person who's on the phone, the scheduler, to say, okay, I can get you into psychiatry within 10 days, or whoever you call. Because often what's happening is people will call and they want an appointment with their primary care doctor to talk through these issues. And they can't get an appointment with their primary care doctor for months. So they let it go. Or they have to wait because they're relying on their primary care doctor to tell them how they can get into these systems. Right? And the people who are answering the phone are schedulers. So when you say to them, but they're like, there's nothing I can do. There's nothing I can do. This is the next available appointment. So I think my number one suggestion would be to have the people who are answering the phones, to have the opportunity for them to get educated about everything that you can offer so that they know where to send people. So that when a mom calls in and says, I'm worried about my kid, they don't schedule them 3 months out with their PCP. They have the knowledge to say, okay, let's talk about what the possibilities are. And then direct people to where they can go and get that kind of care.
A direct referral, essentially.
A direct referral, or even, one of the things people get really frustrated with in the community is getting handed a phone number. That's not what people need.
Yeah.
Right? Okay, I've called, and I'm sure you've all been through this yourselves. Well, now I've called 10 different people today. I've lost an hour of work time. I can't afford that. They need people who will help them do it. I've got you on the phone. Let's make this phone call right now. Let's make this phone call right now. Let's get you an appointment right now. I'm going to transfer you directly to this office so that you don't have to hang up the phone and make another phone call. Losing an hour of work time to navigate trying to get an appointment is a big deal. And a lot of people cannot afford to do it, especially during the hours that the phones are answered.
It can be done in an AI way too, with a high-tech act. Part of that will allow interoperability between your hospitals. So I know that you all are probably going, that act is making my head hurt trying to figure out how to implement all of this. But there will be parts of it that cause transparency. So you can refer within the counties, you can refer within even practices. There are plugins and opportunities as part of it. Doesn't really happen to be required until 2028 through 2030. But there is more transparency with that act from at least your hospital's perspective, because you may not be able to see, your scheduler right now may only be able to see his or her own area. Part of that allows them to be able to see other aspects of what's going on within your system. And that's not the end all at all. They still have to know about crisis stabilization units. They still need to know to ask the right questions. And we all know even to train the people to ask the right questions and to teach that is an ongoing, constant education. But it is something to keep top of mind. And you're absolutely right that that warm handoff and not just passing the baton to someone else and saying, here are the 10 places you can receive care. It can be done, and I've seen it done in other locations if it's planned on a higher scale.
Thank you. And thanks to each of you for the work that you do every day and for joining us today for the panel. Let's give them a round of applause. Thank you.